thank you for organizing this symposium. And I feel like this is a long time need. I've been here for several years. I feel like we've talked about how important it is to have like a programmatic effort, not just, so my talk today is going to focus on the PD1 resistance. And so here are my disclosures. And so, PD1 therapy, and we all know it's become pretty widespread in cancer generally, but what's also recognized is that it's not equally efficacious across the board. So, you have these tumors like melanoma and non-small cell lung cancer, where maybe about 60 to 70% of patients will have some reduction in the size of their tumor. But then you also have thyroid and salivary cancer and ER-positive breast cancer and colorectal MSS, stable colorectal cancer, where barely any responses are seen. And then you have those cancers in the middle, like gastric cancer and ovarian cancer and mesothelioma. So kind of a varied spectrum of response to PD1 therapy. And even if you look at melanoma, it's not like every single person who has a response is just permanently in response. And you could see that these Kaplan-Meier curves kind of slope downwards. And so over time, you see lesser patients having a sustained response. And, this paper was published by Steve Hody a few years ago, and he looked at spider plots of patients treated at Dana-Farber. And I think he had almost 100 patients. And so what's seen is that the patients who respond initially often will stay in some type of response. But there's a difference between people who just progress right off the start, who are called primary resistance or primary resistors, and people who had maybe some transient stable disease or a small shrinkage of tumor and then progress, and they're referred to as acquired resistance. It's a clinical definition, so hard to say how meaningful that is, in terms of the science underlying it. And what's being observed by many people, and this is just one of our summer students actually did this, Clinton, and basically, if you look at a disease type, there's often a set point for PD1 activity, regardless of histology. Like, for instance, if you look at urothelial cancers, or if you look at lung cancers, whether it's adenocarcinoma or squamous cell or whatever, there seems to be a certain set point for PD1 activity. And that's true for across the board of cancers, like pancreatic cancer, pretty much regardless of histology, it seems like it's almost zero. And, it's been known for several years now that the more PD-L1 expression you have, the more response you have. And so if you look at melanoma, if you have like a PD-L1 of 4, just by this arbitrary scale here, you might have about a 70% response rate. And if you have a PD-L1 score of 0.1, you have a 0% response rate. And I think what's important here is that basically a lot of the resistance comes from the low PD-L1 group. You don't see a lot of resistance in the high PD-L1 group. And it has to do with the fact that initial response and resistance all seem to be pretty linked to each other. And, we showed a few years ago that if you have a lot of these CTLA-4 PD-1 high T cells in a tumor, that's more likely to have a response. And some people call them exhausted T cells. Maybe that's a misnomer because they're really tumor-related T cells. And also, our group has shown that there's different factors that seem to mediate response. And like, for instance, the presence of liver metastases, regardless of tumor mutation status or regardless of what the origin of the tumors, seems to indicate lower resistance. Now, what's interesting is that brain metastases, like if you look at that thing right from the bottom, actually doesn't reduce your chance of response to immunotherapy. But what's been shown is that if you use steroids or if there's immune suppression added to it, or what's known as symptomatic brain mets, they seem to be less responsive to treatment. And people are looking to see whether maybe you can spare some steroid treatment at some of the time. And James, who works with Jeff Bluestone, who's now no longer at UCSF now, basically showed that at least in mice, If you looked at liver tumors, they were immune suppressive. They had this like myeloid-derived suppressor cell signature that caused systemic immune suppression, basically. So like once you had a liver tumor, even your sub-Q tumors didn't really respond well to immune therapy in mice. And you know, there's another paper from a group at Michigan that basically collected a lot of tumor from patients with liver mets and essentially showed the same kind of thing. And Max Krummel you know, their lab is shown, I know Chris is here. Basically, if you look at responders mostly from melanoma and head and neck cancer, they come in two varieties, basically. There's a class 1 responders and a class 2 responders. There might be other types too, but the one kind of responder has a lot of NK cells and a lot of what are known as classical DC1s and a lot of CD8 T cell infiltration. And then this other kind of responder has a lot of, or class 2 responders have a lot of CD4, so they have a lot of helper and CDC2 immune microenvironments. And so you can have, I guess the point of this is that if you look at hot tumors, they come in varieties. It's not like they're all the same exact, you know, underlying under the hood. And so he's proposed this model, which I think is great, which, you know, kind of looks at these different tumor microenvironments, and instead of just saying it's hot, you're going to respond, tries to classify them into multiple different axes, and, you know, like a more kind of like a wound healing subtype, which is that Th2 ILC2 type, or a more tissue development or commensal, like the Th17, like that's seen a lot in the colon, and kind of proposed these archetypes across the tumor types. And I feel like that's one step to try to understand who really responds to PD1 therapy. Now, at the same time, it's been more and more become established that exhausted T cells are not really reactivated to a great extent by PD1 therapy, and they have a finite lifespan, only a few weeks. So how come immune therapy lasts so long when these exhausted T cells are only reactivated for a few weeks? That's the question in our field to some extent. And one model that's been proposed is that the exhausted T cells don't last long. Your PD1 therapy only works for a few weeks in those patients, but then you have a constant inflow of new stem-like T cells into the tumor, and so this kind of cycle keeps on going, and that's why you get those long responses, like I was showing in that first slide. And so the question in our field now is like, what do we do next? Like, if somebody develops resistance to PD1, what is the next step? So one target is LAG3, and this was a poster that was presented by Paolo Ascierto at ASCO like a few years ago now, where he looked at this LAG3 combination with Nivo, and the response rate was kind of disappointing. If you looked at unselected patients, the response rate was 11%. If you looked at LAG3 less than 1%, only 3 patients responded. If you looked at the high LAG3s, it was 16%, and that was that first LAG3 combination waterfall plot. And if you looked at the spider plots, again, you didn't get a lot of response in the unselected patients or in the LAG3 less than 1% of patients, which is basically most patients who have progressed on PD1. And there's a lot of other targets too that are under investigation. You know, we talked about LAG3. There's also CTLA4, there's TIM3, TIGIT, BTLA, and there's these TNF family receptors, GITR, OX40, 4-1BB, and ICOS that are, at one time, people thought weren't going to be effective, but now we are looking at, with the LAG3 experience, which I'll just talk in a minute, people are looking at these things as potentially being useful. And so the one study that I think has been kind of like thought-provoking is this Checkmate 67 study, where patients with melanoma were stratified into 3 groups, Nivo, Ipi, Nivo, or just Ipi by itself. And the Nivo Ipi arm looks like it was positive in terms of progression-free survival advantage. The hazard ratio was 0.79. And then if you looked at the different groups, it seems like a lot of the benefit was in the BRAF mutant tumors, not in the BRAF wild type tumors, which were pretty much the same. And the hazard ratio was really not statistically significant. And they also looked at liver metastases, because now everybody's looking at this issue. And if you looked at those different groups, you actually got benefits in both groups, but except that with liver metastases, neither combination was super effective. Without liver metastases, all the combinations seem to work better. And if you look at LAG3, again, it's basically like a sensor for the presence of MHC class 2. And it's present on Tregs, it's present on NK cells, it's present on exhausted T cells. It seems to be expressed a lot more in the pancreas and in the heart, which could be a problem for adverse events. But what's been shown like a few weeks ago, or I guess a few months ago now, is that positive PFS, which went up from 4.6 months to 10 months for the Nivo-Rela arm. However, if you look at the stratification factors, a lot of the benefit was not in the LAG3 positives, which was what was seen in that first trial, but really in the PD-L1 negatives. So if you look at the PD-L1 positives, they didn't seem to get a lot of benefit from the combination. Most of the benefit was basically in the PD-L1 negative. So, just I think further complication to what's going on. And I kind of drew this by hand. I don't know how accurate this is, but what seems to be the case is that if you look at Ipi-Nivo, you get benefit across the board, regardless of how immune infiltrated the tumor is. If you look at LAG3, the Rela-Nivo combo, looks like a lot of the benefit is in the PD-L1 low group and not in the PD-L1 high group. And I think that just illustrates that there's differences between these two checkpoints, and we don't have enough data on the ICOS right now, but I think that leads to this question of, what combination do we take forward? And a lot of the combinations have been disappointing, I would say, in terms of single agent activity. Like, for instance, if you look at the Merck anti-LAG3 PD1 combo, it was 27%. Although it's 27% too low, now I think it might be fine because LAG3 with 11% was a positive phase 3 trial. So maybe we don't need a lot of activity in the resistant setting to really proceed forward. And so the trial we've proposed and that Laura wrote up is basically this one. It's a combination of CTLA-4, LAG3, and PD1 and ICOS. And here's the schema. And the idea is to have a brain metastases group who have asymptomatic CNS disease, and then another arm that has no CNS disease. And I think the idea will be to use this as a forerunner for trials across the board, in patients with brain metastases, and hopefully we'll get it going in the next few months here at UCSF, and then try to get other brain metastases specific trials ongoing, so and help to have like kind of a lot of choices for patients with. And so I want to thank our contributors. I got these photos yesterday. Sorry if they're not the most useful, but thank you, and happy to. Thanks, Dave.